So our next speaker is Dr. Nicholas Raybon. He's a pediatric and congenital electrophysiologist with Norton Children's Heart Institute. He earned his medical degree from Wayne State University School of Medicine and completed a combined internal medicine and pediatrics residency at Children's Hospital of Richmond at VCU. He went on to complete a pediatric cardiology fellowship at the Medical College of Wisconsin and advanced training in electrophysiology at Vanderbilt University Medical Center. Dr. Raybon specializes in diagnosing and treating heart rhythm disorders in children and patients with congenital heart disease, including procedures such as ablations, pacemakers, and defibrillator implantations, and 3D heart mapping. He's board certified in pediatrics, internal medicine, and pediatric cardiology, and is a fellow of the American Academy of Pediatrics. He is also a member of the Heart Rhythm Society and PACES. Welcome, Dr. Raybon.
Thank you. Can you guys hear me?
We can hear you.
All right,
I
perfect.
can see you.
Good. Good morning, everyone. I'm Nicholas Raybon. I will be talking this morning about sudden cardiac death in the ACHD population and the need to maintain a high index of suspicion. Sure, I can move. Oh, yep. All right, so my objective this morning is to convey an understanding of the risk factors and the epidemiologic aspects of sudden cardiac death in adults with complex CHD. My hope is that at the end of this talk, you can recognize clinical and ECG indicators that warrant increased surveillance and intervention. And my goal is for everyone to acquire knowledge of guideline-recommended approaches for genetic testing, management of arrhythmias, and the application of devices in these patients with elevated risk. So, sudden cardiac death is a very common and devastating cause of death in the ACHD population, the risk of which is directly correlated with cardiac lesion complexity and/or the presence of genetic predispositions. Patients with repaired and unrepaired congenital heart disease have highly variable substrates that may lead to sudden cardiac death. These include both arrhythmogenic and non-arrhythmogenic substrates. And on top of it all, it's highly unpredictable. There's a high degree of anatomical and surgical heterogeneity in this population, which makes prediction and determination of risk incredibly difficult. Sudden cardiac death comprises about 15% of all mortality in the general population, about 5.6% of annual mortality in the US, primarily due to fatal arrhythmias. And this risk is increased further in the ACHD population subset, with about 25% of all mortality in CHD due to sudden cardiac death, and there's a median age at death in the third and fourth decade of life. Annually, the incidence of sudden cardiac death in the entire CHD population is only about 0.1%, but this is still much higher than in age-matched controls, and this number is increasing as more children with congenital heart disease survive to adulthood to join the ACHD population. Oh. There we go. Sorry, I clicked the button too many times. 1 second to fix this. I don't know why this is not going. All right, we're gonna just do this. Can you help me with this? I don't know why this is not staying up. Sorry, 1 second, having a little technical difficulty. Why is it going blank? Okay, anyway. All right, so as I mentioned, sorry about that. As I mentioned before, sudden cardiac death is a devastating event that has a huge impact on families and communities. And in order to try to prevent these events, we have to understand some very critical aspects of the problem. Specifically, we have to answer the questions: who is affected? What is the underlying pathophysiology and/or triggers? What, if any, are the early warning signs, and what therapies are most effective at preventing these events? This image illustrates how improving outcomes related to sudden cardiac death in patients with CHD requires comprehensively addressing and studying many different aspects of these events. Understanding the different pathophysiology and phenotypes of sudden cardiac death in combination with data obtained from autopsies and creating a structured taxonomy allow us to gain a better understanding of disease processes and prediction of risk, while recognizing early warning signs, providing adequate and high-quality resuscitation, and implementing strong preventative therapies will also help maximize outcomes. Sudden cardiac death in this population remains a very complicated and heterogeneous problem that requires multiple different approaches tailored to individual patients. The impact of surgical repair on congenital heart disease also cannot be understated, and there's a clear link between the incidence of sudden cardiac death and the complexity of the lesion in subsequent repair. Oftentimes, these patients undergo multiple intracardiac surgeries throughout their lifetime and may develop myocardial hypertrophy, subendocardial ischemia, and scar formation that predispose them to sudden cardiac arrest. We try to categorize these lesions into high, moderate, low, very low risk of sudden cardiac death, but recognizing the surgical factors that increase an individual's risks remains imperative. We'll come back to this figure a little later in the presentation. Additionally, efforts to predict sudden cardiac death using genetic factors in the general population have been largely unsuccessful, but there's a distinct genetic landscape in congenital heart disease that makes this a very promising area of research. And a genetic cause can be identified in about 35% of CHD cases. Genetic factors may also influence sudden cardiac death risk in congenital heart disease through associations with ventricular dysfunction or arrhythmias. For instance, there's mutations in transcription factors, TBX20 and NKX2.5, that can cause septal defects and dilated cardiomyopathy. The RASopathies contribute to cardiac hypertrophy and when combined with pulmonary stenosis. And then sarcomeric protein mutations such as MYH6 and MYH7 are linked to both congenital heart disease and cardiomyopathies. Common variants may also predispose to ventricular maladaptation and sudden cardiac death. For example, in Fontan patients, variants that activate the renin-angiotensin-aldosterone system and increase catecholamine release are associated with poor hemodynamics and higher mortality. Alternatively, in tetralogy of Fallot, variants in the hypoxia-inducible factor gene correlate with RV dilation and dysfunction. And this all highlights the importance of genetic evaluation in patients with congenital heart disease. As I mentioned before, the vast heterogeneity of the pathophysiology of sudden cardiac death in congenital heart disease leads to great difficulty in risk stratification. For example, we know that inducibility of sustained monomorphic VT in patients with repaired tetralogy of Fallot conveys a 5-fold risk of clinical VT and sudden cardiac death, which is why these patients frequently undergo EP studies and ablations prior to things like pulmonary valve replacements or when there's a suspicion of ventricular arrhythmias. On the other hand, inducibility of VT in patients with transposition of the great arteries has no prognostic value that we've yet seen in the literature. We do know that certain features in patients with congenital heart disease increase the risk of sudden cardiac death, and these include things like prior palliative shunts, unexplained syncope, frequent ectopy, atrial tachycardias, prolonged Q restoration, and the list goes on. I'll discuss some disease-specific risks and considerations next, but recognition of some of these overarching features is critical in all congenital heart disease. Moderate complexity lesions include things like tetralogy of Fallot, aortic stenosis, coarctation of the aorta, and Epstein anomaly. And I'm not going to go through each of these in extreme detail because it's a very large list. But the various risk factors for sudden cardiac death are listed in this table. I'd like to specifically point out that risk stratification in these patients involves a combination of clinical, electrocardiographic, and imaging markers. I'll discuss some risk scoring and stratification a little later, but it's worth noting two things. First, that unexplained syncope is something that will come up over and over again as a risk factor, regardless of the underlying lesion. And second, beyond that, the risks and considerations in these patients are generally quite lesion specific. Tetralogy of Fallot is perhaps one of the best studied congenital heart lesions, and there are very well circumscribed risk factors for clinical VT in these patients, including history of prior palliative shunts, wide and or fractionated QRS complex, and ventricular dysfunction, among other things that you can see in this list. In some of the more complex lesions, including univentricular physiology, patients have a substantial risk of sudden cardiac death. The risk is driven by a combination of both arrhythmic and non-arrhythmic mechanisms, including ventricular arrhythmias, progressive ventricular dysfunction, and circulatory failure. More high-risk features in this physiology include atrial tachyarrhythmias, protein-losing neuropathy, ascites, worsening ventricular function, and a generally longer duration since their Fontan completion. The various societies like the ACC, the AHA, and Heart Rhythm Society emphasize that risk stratification should consider the presence of these factors, including hemodynamic sequelae, and that device therapy, such as an ICD, for primary prevention of sudden cardiac death remains a very highly discussed and individualized decision due to the competing risks and technical challenges with device implantation in this population. I'll talk about that in a little bit as well. Another complex lesion is transposition of the great arteries. Sudden cardiac death risk is also elevated in TGA, particularly in those who have undergone an atrial switch repair, such as a mustard or setting. Disease-specific considerations include a high prevalence of ventricular arrhythmias due to surgical scarring, systemic RV dysfunction, and atrial arrhythmias, which often precede ventricular arrhythmias. Additional risk factors are prior VSD closure, symptomatic heart failure, and decreased right ventricular ejection fraction, QRS duration that's prolonged, and unexplained syncope, as I mentioned before, and severe tricuspid regurgitation. These patients may also have coronary orifice stenosis and myocardial perfusion defects that may further contribute to their arrhythmic risk. Therefore, the prevailing societies recommend aggressive management of atrial arrhythmias, including ablation and beta blockers to reduce sudden cardiac death risk and ICD shocks, but emphasize that once again, risk stratification and device implantation decisions must be individualized. The last complex lesion that I'm kind of just going to cover here, just for sake of time, is truncus arteriosus. The risk of sudden cardiac death in this population is most associated with multiple prior surgical repairs, coronary artery anomalies, ventricular dysfunction, and/or ventricular hypertrophy. Most adults have undergone a childhood repair, which typically involves a VSD closure and an RV to PA conduit placement, but residual or progressive ventricular dysfunction, conduit failure, and truncal valve disease are common and continue to contribute to arrhythmic risk as patients grow older. Coronary anomalies, either congenital or acquired post-surgery, further increase the risk of ischemia and arrhythmia. In the presence of pulmonary hypertension, aortic dilation, and progressive myocardial fibrosis also contribute to this arrhythmic substrate. Sudden cardiac death may result from ventricular arrhythmias, but non-arrhythmic mechanisms such as the rupture of the pulmonary trunk or aorta, intrapulmonary hemorrhage are also reported. So how do we monitor for such a various and wildly heterogeneous population? There's many different ways to do it, and overall, we are very aggressive about monitoring for risk factors of sudden cardiac death. Systematic and ongoing monitoring is critical for early identification of patients at increased risk of sudden cardiac death in all congenital heart disease. There are prospective risk models such as the prevention ACHD score, which I'll talk about in a little bit. These have demonstrated that incorporating regular assessment of arrhythmia burden, ventricular function, and QRS duration significantly improve risk stratification. Temporal trends are particularly important. So progressive QRS prolongation and worsening ventricular function over time are both independently associated with markedly higher risk of sudden cardiac death, which underscores the value of serial rather than single point measurements. And once again, lesion-specific risk stratification enables more accurate identification of high-risk individuals. Regular monitoring can also facilitate timely intervention, such as escalation of antiarrhythmic therapy, consideration of catheter ablations, and evaluation for device therapy, such as an ICD, transvenous, sub-Q, or the other types that we have available. Importantly, even patients with mild or moderate lesions may develop new risk factors over time, highlighting the need for lifelong surveillance. Additionally, genetic testing can identify pathogenic variants associated with inherited arrhythmia syndromes and cardiomyopathies that may underlie sudden cardiac death in congenital heart disease. Identification can clarify the etiology of sudden cardiac death, inform prognosis, and guide management strategies, including family screening and risk stratification for device therapy. Genetic testing is particularly valuable in cases of unexplained cardiac arrest, family clustering of CHD or SCD, or when syndromic features are present. Cascade genetic testing of at-risk relatives is strongly supported when a pathogenic variant is identified, as this enables targeted clinical evaluation and preventative strategies for family members. Genetic counseling is essential throughout this process to address the complexities of variant interpretation, psychosocial implications, and reproductive risk assessment. The European Society of Cardiology and the National Society of Genetic Counselors actually recommend a multidisciplinary approach, including detailed family history assessment and collaboration between cardiology and genetics specialists to optimize the use of genetic testing in the evaluation and management of sudden cardiac death risk in the congenital heart disease population. This all highlights, again, the importance of genetic testing and genetic counseling in congenital heart disease patients. Two relatively recent studies were designed to identify and validate factors associated with sudden cardiac death in adults with congenital heart disease. The Prevention ACHD study, which was a case control study, combined 165 patients with sudden cardiac death, along with 310 match controls from the Dutch registry and Toronto Congenital Cardiac Center for Adults, and identified factors that were then combined with a CHD lesion-specific baseline risk of sudden cardiac death to create a point-based risk score, which was then prospectively validated in a single-center cohort study of 783 patients, who were followed for 2 years. If you'd like to scan that QR code, it'll take you actually to a web-based calculator that provides an annual risk of sudden cardiac death in a disease-specific context, which is a very useful resource in managing these patients. Similarly, a risk prediction model from the Spanish Adult CHD Network merged retrospective cohort data with case control study data to identify 278 events of both fatal and non-fatal cardiac arrest. Congenital heart lesions were clustered into 4 risk categories, and here's that figure from before. And they clustered it into high, moderate, low, and very low risk, and then combined it with identified predictors to generate a 5-year risk estimate. What I would like to point out is that high-risk features common to both scores include systolic dysfunction of the systemic or subpulmonary ventricle, a wide QRS complex, and ischemic heart disease. So now let's talk about ICDs. Any stratification scheme for primary prevention ICDs should carefully balance anticipated benefits against potential risks. Competing causes of mortality account for a non-negligible percentage of deaths in patients with congenital heart disease, such that they can't be ignored. Moreover, even if the terminal event is sudden cardiac death, it may not be due to a shockable rhythm and therefore won't respond to ICD therapy. Importantly, heart failure is increasing in prevalence in the aging population with congenital heart disease. Less than 50% of sudden cardiac arrests in patients with heart failure are due to shockable rhythms, with rates as low as 27% in certain clinical subtypes. And in addition, ICD-related complications are substantially higher in the congenital heart disease population, have to be factored into this balance. The ideal candidate for a primary prevention ICD has a high risk for sudden cardiac death due to a shockable rhythm, low risk of dying from other causes, low risk of ICD-related complications, and is in an environment in which associated costs are affordable. The first ICD recommendations specific for congenital heart disease patients were published in 2014 as an expert consensus statement from both PACES and HRS. Recommendations regarding ICD indications for children and adults with congenital heart disease have subsequently been published by the AHA, ACC, and HRS in 2017, the European Heart Rhythm Association in 2018, and the European Society of Cardiology in 2020, and then PACES once again published guidelines in 2021. The strongest recommendation to place a primary prevention ICD is for patients with sudden cardiac arrest due to a ventricular rhythm or arrhythmia after exclusion of all reversible triggers, though it is also clear that if a life expectancy is less than 1 year, the patient has incessant VT or VF, has severely symptomatic heart failure, or severe psychiatric illness, device implantation may do more harm than good. It's worth emphasizing that guidelines are not the same as prediction models or risk stratification tools and should not be interpreted as such, and the decision to place an ICD is still a very individualized one. Implanting transvenous ICDs in patients with congenital heart disease poses very unique challenges. Venous access is complicated in up to 15% of cases due to obstructions or anomalous or absent veins. Anatomic barriers may hinder lead fixation, such as a smooth-walled subpulmonary ventricle or subpulmonary AV valve disease. In patients with transposition of the great arteries who have undergone a mustard or stenting procedure, the superior baffle has to be patent, and care has to be taken to avoid phrenic nerve capture near the systemic ventricular wall or left atrial appendage. For patients with intracardiac shunts, transvenous leads carry a risk of thrombosis and embolism, warranting cautious consideration of alternatives like shunt closers, sub-Q ICDs, or epicardial systems. Device extraction is also increasingly used now for lead failure, infection, or to maintain MRI compatibility if no other leads are abandoned. Altered anatomy from limited venous access, prior surgeries, baffles, conduits, stents, or occluders can complicate the extraction. However, reports show high procedural success and safety using tools such as laser lead extraction, mechanical extraction, or rotational sheaths, though unique complications can occur, including subpulmonary AV valve injury, especially in patients with transposition. The sub-Q ICD was actually developed for congenital heart disease patients with complex access issues and is proven as effective as the transvenous ICD with similar success in congenital heart disease and non-congenital heart disease patients. However, while it avoids transvenous lead complications, the SICD lacks anti-bradycardia and anti-tachycardia pacing, something that's often vital in the management of arrhythmias in congenital heart disease. It is particularly advantageous in patients with limited vascular access, prior device infection, intracardiac shunts, or Fontan circulation. Fear of sudden cardiac death has also historically led to exercise restriction, though less than 10% of events in congenital heart disease patients occur during activity. Overall, the physical and mental benefits of exercise outweigh risks, with exceptions such as patients who have undergone an atrial switch operation where actually greater than 80% of sudden cardiac death occurs during exercise. Guidelines recommend ICD recipients with CHD limit participation to non-competitive, non-contact sports, and the ICD should not justify higher risk activity than otherwise advised. But again, this is a very individualized discussion and decision. Despite careful planning, ICD complications in congenital heart disease remain high. This table lists some that I haven't gone through necessarily, but there are many different types of complications associated with device implantation. Device-related issues can occur in about 26% of patients with CHD, and inappropriate shocks occur in about 25% of patients. And with rising CHD survival, long-term morbidity from these devices is likely to increase. Devices are not our only tool in the toolbox. We have several adjunctive therapies that are vital to the aggressive management and prevention of sudden cardiac death, which I won't go into in too much depth for sake of time right now. But these include antiarrhythmic therapy, catheter ablation, especially for atrial arrhythmias or prior to transcatheter pulmonary valve implantation, and anti-tachycardia pacing strategies to avoid inappropriate ICD shocks. So kind of wrapping things up, it's good in patients with adult congenital heart disease and actually congenital heart disease in general to maintain this very high index of suspicion. The American College of Cardiology, the AHA, and the Heart Rhythm Society emphasize that sudden cardiac death is a leading cause of mortality in congenital heart disease patients with risk significantly higher than the general population and a median age of death in the third or fourth decade of life. Risk is greatest in patients with moderate or severe complexity ACHD, especially those with prior intracardiac surgeries, ventricular dysfunction, or arrhythmias. High-risk features include unexplained syncope, that word again, frequent ventricular arrhythmias, QRS prolongation, and reduced ventricular function. The societies recommend that unexplained syncope in moderate or severe ACHD should prompt thorough evaluation, including an electrophysiological evaluation, as it may signal increased sudden cardiac death risk and guide consideration for primary prevention ICD implantation. Early identification and management of arrhythmias, as well as referral to specialized ACHD centers, are associated with reduced mortality. And the rationale for vigilance is this heterogeneity of the ACHD population in anatomy and repair, which complicates risk stratification and necessitates very individualized assessments and discussions to prevent these devastating events. However, there's still a lot to learn. Our knowledge gaps are big. It's we need to have a better understanding of the epidemiology of sudden cardiac death. We need to have a better understanding of early warning signs and risk factors. We need to gain more data for optimal approaches for resuscitation in patients with congenital heart disease. And there's so much more. I mean, there's so much research that's yet to be done in terms of finding these lesion-specific risk factors and overall preventing this devastating event. And that's sort of all I have. If you want to take a look at the sources I've drawn my information from, you're welcome to scan this QR code, but otherwise I'm open for questions.
Thanks so much, Dr. Rabin, for your expertise. I will just give everybody a few moments to gather their thoughts in terms of questions. There are a couple questions in the Q&A section. We have a question that says, which symptom of syncope holds a higher priority over the other?
Yeah, I'm reading that right now because I think there was a preceding one that says symptoms of syncope may include dizzy or lightheadedness, weakness, nausea, blurred vision, cold sweats, tunnel vision, loss of consciousness. I personally think that loss of consciousness probably holds the highest priority over all of them. Things like dizziness or lightheadedness, weakness, nausea, cold sweats, palpitations, tunnel vision, those are relatively non-specific and may or may not be related to arrhythmogenic things. In this population, though, I think all of these kind of warrant a thorough history and physical, maybe some more testing. But definitely if a patient loses consciousness, that would be a red flag in my head, especially in the congenital heart disease population.
From a cardiologist perspective, too, I would agree with you. Which genetic testing company, or is maybe there a specific company that you use in your practice, provides the patient and their provider a clear pathway for cardiac risk, and/or the expectations for cardiac issues throughout their lifetime?
Gotcha. I'm not sure if I can answer this with a lot of accuracy. I'll be honest, my practice is not has not been very long so far, but I don't necessarily have a favorite genetic company. That might actually be a better question for a genetic counselor. Because I think based on where I've trained, it's generally whatever company we have a relationship with. And I've not really delved into it too much, but I don't feel like I've ever found a difference in quality of results. I think what's more important is actually to have a qualified and a very good genetic counselor to help interpret the results, no matter what company it comes from. I think having someone like that to kind of help guide the discussion, understand all of these different variants of unknown significance, and what therapies need to be pursued and or monitoring need to be pursued for all of the different types of unexpected results you might get back, is more important, I think, than necessarily which company we use. And I think sometimes that might just be more of an institutional thing.
The next question is, should there be a genetic counselor added to the adult congenital heart disease team?
I mean, in my opinion, I think that's that's always an added benefit. I think that's someone who could bring a lot of value to the team. I know it's not necessarily, again, there's other sorts of complex issues in terms of availability and hiring and things like that. But I think having an avenue to at least discuss a patient with a genetic counselor would be very helpful in most cases.
And I will say that we do have a genetic counselor that partners with all of our congenital cardiology group. So that is something that we also found important and in our particular institution do have.